السلام عليكم ورحمة الله وبركاته. Brothers and sisters.
وعليكم السلام ورحمة الله وبركاته.
We start our session inshallah by recitation of Kitab. Okay, I understand that you have just finished your class with Dr. Nami, if I'm not mistaken. So just inshallah today we'll continue the second part of stable ischemic heart disease. I'm just flipping with you that you can refresh or remember the point we have covered yesterday. And if you remember, we started with introduction epidemiology, then etiology and pathophysiology, then go overview about the clinical presentation, diagnosis and prognosis. And then the last part, we started to continue about the treatment or the pharmacotherapy, and we understand that in terms of medication, we have different category with different rule in stable ischemic heart disease. And I think this one we have discussed yesterday, the general treatment approach, when we focus on controlling some of the risk factor and giving some intervention to prevent cardiovascular event, the future cardiovascular events, and some intervention or some medication would be given for the symptomatic treatment, which anti-ischemic treatment or anti-angina treatment. I hope up till now you still remember and can follow. So in the pharmacotherapy, we discussed that we have two main pharmacotherapy domains in terms of the outcome. The list of medication that target or can affect the mortality and the risk of future cardiovascular events, and the type of medication that only can work on the symptoms and quality of life. And we started to continue to talk about maybe this treatment, the one having effect on the cardiovascular events. We discussed the lipid modifying agent, if you remember, and we discussed the ACE inhibitor. Okay, then we highlight the antiplatelet, and we highlight maybe the antiplatelet of choice and when to use dual antiplatelet, if you remember, and for how long, especially those after will be stabilized after a cardiac attack, how long. And we present this one, I think, toward the end as an overview of the antiplatelet to be used. And the last one regarding the anticoagulant. Sometimes antiplatelet with anticoagulant, this very special cases, usually they have thrombosis in treated or thrombosis that needs treatment or at higher risk of thrombosis. Though those special candidates will have on top of the antiplatelet or replacing the antiplatelet sometimes anticoagulant. This not a routine recommendation for all the patients. They can receive the anticoagulant, but antiplatelet, of course, for all unless contraindicated. Okay, this I think what we have just reached yesterday, if you remember. Still survive? Remember. Oh. Today, inshallah, we will start to discuss the anti-anginal or anti-ischemic therapy, which actually it is very several agents have been shown to help in the anti-ischemic chemotherapy of given medication, in the case. But what I want from you in the very beginning, actually on the way, if you have any points, any questions, just type in the chat. I will take it all, inshallah, toward the end. It is good to know that anti-ischemic, as we mentioned, it is just focusing on the symptomatic treatment. Okay, this one very important. Starting, of course, with the most important, the beta blocker. So beta blocker we can consider the most important anti-ischemic, the first line, and the one supported by large evidence. But we have also to understand that beta blocker in ischemia in general, sometimes the evidence, the outcome of the trial that give us the evidence is different, meaning they show symptomatic treatment, but they didn't show any mortality benefit when we use this agent for today for stable ischemic heart disease. Okay, so we understand that beta blocker have not been shown to reduce the cardiovascular events or mortality in patients with stable coronary artery disease or stable ischemic heart disease. We understand this. They show benefit, but not to the extent of the mortality, right? Okay, I don't want anyone to confuse this. These didn't show benefit at all. They show benefit, but not the extent of mortality. And this, I think, we highlighted yesterday that all these agents in this particular indication, the stable condition, the impact is on the symptomatic treatment. What in patient, in MI patient, the myocardial infarction happen and the cardiac attack happen. For those patients, mortality benefit is there. So inshallah, you will show mortality benefit next week in the ACS. So current data also it doesn't recommend even the beta blocker, even in MI. After 1 year, it is not the same mortality benefit within the first year. Okay. Which one in general in the stable coronary artery disease, our condition, all of the beta blocker by somehow is equally effective. But of course, we have inter differences between different agents, right? So sometimes, yeah, the choice can be based on the comorbid condition, whether maybe you want maybe beta blocker that have some favorable impact on the glycemic control, for example. We have two agents I will show you. According to the cost, according to the schedule of daily administration, the number of daily doses, especially if older patient. For example, we have maybe the nebivolol, one of the recent one. This quite beta selective and also has vasodilating efficacy, and it can cause release of nitric oxide. And because of the vasodilating efficacy, it tends to be less associated by insulin resistance. In another term, improve insulin sensitivity. And that doesn't have any maybe harmful effect on the lipid profile. Also, the carvedilol, one of the non-selective beta blocker, can the same improve insulin sensitivity based on the same rationale of having vasodilating effect. So this one perhaps can be of relative advantage if you have the if you have diabetic patient, but it doesn't mean that diabetic patient can only get this one, nebivolol or carvedilol. I didn't mean this, but I do mean that in patient receiving or have an option of variety beta blocker, sometimes individual characteristics can be of relative advantage if available. Okay. So the side effect, of course, this one you go back to the body system and review back the pharmacology. The side effect of beta blocker, but we have to mention here because it's very important, and some of the uses actually will be later maybe modulated, or contraindication actually can happen maybe as a consequence of those safety issues. From the side effect, of course, we have to mention about the bradycardia, hypoglycemia, the depression, the bronchospasm. In patient with very active reactive airway disease, means severe asthma, severe COPD. This one would be problematic, so it can be or should be used with caution. If you remember yesterday, we talked about a form of the stable IHD that is not actually related to the atherosclerosis. This related to coronary vasospasm, the brain's metal angina. In this particular form, beta blocker is the least recommended option. Actually, should not be used. Okay. This overall, you can see here overall the agents, the selectivity, the precaution. Okay, so one by one you can refer to, inshallah. Okay, so the first anti-ischemic is beta blocker, and we have highlighted the place and everything. The second, even in the importance also, the calcium channel blocker. Calcium channel blocker, of course, as you know from your pharmacology background, we have non-dihydropyridine, the dihydropyridine. So it is good to know first, the non-dihydropyridine can be added on to the beta blocker to help to achieve the heart rate goals. One. Also, they can replace the beta blocker in case of the maybe clear contraindication or severe adverse effects happen with the beta blocker. And this CCP this one can be recommended for the brain's metal angina, for which the beta blocker cannot be used. Effective, but as we will highlight in each and every one, it is not associated the long-term cardiovascular outcomes in terms of mortality and it's just symptomatic treatment. So what about the short-acting dihydropyridine, means the nifedipine, for example, the one of the very maybe famous calcium channel blocker to be offered in a hospital setting. Actually, this one used to impose or induce exacerbation of the angina, actually, and this phenomena called coronary steal. This maybe reflex tachycardia and a change in the rapid change, actually in heart rate that affect the blood the circulation within the coronary artery, and this overall is not recommended currently to be used. Long-acting dihydropyridine, this one, the amlodipine and felodipine, in terms of symptomatic control, symptoms relief, can be as beta blocker in terms of the overall symptomatic relief. But we have to maybe to understand that this symptom relief actually has been reported from trial, the clinical trial, which use the ability of the patient to exercise, to have the same exercise tolerance as the marker, as the endpoint. We call surrogate marker, means intermediate endpoint for the trial. Of course, the final endpoint is the symptom itself or the mortality. So if the surrogate endpoint, usually it is not that maybe strong enough, but it shows some symptomatic relief that we need to understand. And actually, the dihydropyridine, when we talk about the amlodipine and felodipine and this class, of course, all of us know that it may cause maybe flushing, reflex tachycardia, and the headache. But from the other hand, if you give dihydropyridine and beta blocker actually can overcome this side effect. This reflex tachycardia with beta blocker will not be there, so beta blocker dihydropyridine combination, the side effect be that pronounced in this case. Okay. The non-dihydropyridine, the one we called maybe as a replacer or as add-on to the beta blocker, this one has sufficient evidence and sufficient trial, and they actually assess for the symptom control, the frequency of the angina attack, beside the exercise tolerance that we mentioned in the dihydropyridine. And compared to beta blocker, can be of the same symptomatic relief, but with less depression. Depression, one of the side effects of beta blocker. So it seems to be maybe of a relative advantage in clinical use. But we have to understand that usually, if you have non-dihydropyridine and beta blocker together, the risk of bradycardia is much more. So actually, it has to be done with extreme caution if to be considered in a given case to avoid risk of the bradycardia or heart block. Heart block we will discuss inshallah in the arrhythmia. So just this overall the dosage. So the third anti-ischemic, which the third agent of traditional anti-ischemic actually is the nitrates. Of course, nitrates can be used in the acute angina, can be used as a prophylaxis, can be used also for having some other maybe action beside anti-anginal like antiplatelet, antithrombotic, but it is not that the indication. Here we use for anti-ischemic property. The tablets, of course, we have this maybe to educate the patients about the amber-colored bottle and the lifespan and how to storage to maintain the efficacy of the GTN tablet as much as we can. For the treatment and prophylaxis, where and with whom we can use nitrate? Nitrate actually can be used with beta blocker, the CCB, the one that we mentioned, as add-on therapy for the symptom relief. And we have also in the long term, we have nitrate, which is the isotopic mononitrate, which maybe have a longer duration compared to the dinitrate and with better side effect profile. I think also, as I just confirmed that according to pharmacology background, of course, you know that the nitrate action inside our body is dependent on the endogenous thiols. So if this endogenous thiols has been depleted, so the action with nitrate will not be that much, and we start to have the nitrate tolerance. So to keep this endogenous thiols is in and not to be depleted much, and to keep the nitrate effective, we have to design the scheduling of giving or administering the nitrate to have a nitrate-free period. And this one at least will be among maybe around in the range of 10 hours and sometimes more. Okay, if we didn't do this, the endogenous thiols will be depleted, the endocellular dysfunction will happen, and the nitrate will not be longer effective. And usually, nitrate-free period will be in the time that has the lowest risk for ischemia, means the night time. In the early morning, the highest risk. So usually we give the medication in the early morning actually. So the scheduling of the nitrate will be giving the medication early morning, and design the nitrate-free period will be night to accommodate and to parallel for the risk of the ischemia, which is very high in the early morning. And this that's why actually some say maybe as Muslims, when we wake up for the Fajr prayer in the early morning and do some activity, go to the masjid and do the prayer, it's very healthy sign to counter for the ischemia attack. The common side effect, of course, nitrate is vasodilator. Vasodilator means hypertension. Vasodilator means headache. So this one is very common. And of course, for those receiving other vasodilator for other indication, like maybe erectile dysfunction, this one, of course, can be additive vasodilating effect, and severe hypertension can happen. So now, brother and sister, we talk about beta blocker. We talk about calcium channel blocker, because we talk about nitrate. I call them as a traditional anti-ischemic agents. What about the rest? We have so many, maybe 5 agents. All of them are maybe relatively new compared to the traditional agents. One of them, or the first one of them, is ivabradine. Ivabradine, I believe you receive maybe some information about ivabradine in heart failure, of course. May I ask what do you know about ivabradine from heart failure? When it is indicated something like this? It is so weird for a lecturer to ask about some other lecture topic, right? but it is related. Ivabradine, what do you know about ivabradine, brother and sister? In the chat if you are not comfortable to unmute the mic. Did you hear about ivabradine in heart failure? Of course. Did you hear? Just yes or no? Hello? Are you okay, brother and sister? You can type in the chat. Just okay, yes, Alhamdulillah. So we have one response, Alhamdulillah. Two, oh, so generous for you. Okay. Ivabradine. Okay. So of course, ivabradine is one of the medications that have several cardiovascular. Okay. Not remember. Okay. Sorry. The team is that. Okay. Okay. Problem with the team. Okay, no problem. Ivabradine, of course, one of the medications that have several cardiovascular indication, which is common among the cardiovascular medication, and have some unique, maybe characteristic. Ivabradine, according to the information that I'm sure you have, ivabradine is selective inhibitor of the sinus node running the funny current. The gist that we need to know this, it has lowering or slow can lower the heart rate, slow the heart rate, with no effect on the contractility of the myocardial muscle or even the blood pressure, no hemodynamic effect, and this one is relatively advantage. So placement therapy actually it can be of option for patients who have contraindication or intolerance to beta blocker, or in some cases can be add on the beta blocker in patient with very resting heart rate, patient with tachycardia, the sinus tachycardia is very high, that beta blocker alone cannot control. Okay. So ivabradine actually have been shown to improve symptoms, hospitalization, the symptoms of fatal and unfatal MI, the need for revascularization, all this have been improved, especially in patients with, as I mentioned, the stable coronary disease, moderate left ventricular dysfunction, and the heart rate, the resting heart rate is more than 70. Also, compared to the beta blocker, we can say it has maybe impact on the heart rate with no the negative tropic effect of the beta blocker, which is really good. Okay, the dose is of course when the heart rate of the patient come to as low as 50, it is indication that you have to think to discontinue or decrease depending on the case. Is not suitable to consider this medication in patients with atrial fibrillation. It will be very challenging for them. And it has been shown also when you use with the non-dihydropiridine calcium channel blocker can have extensive prolongation effect, the QT interval. One of the main side effects and frequently reported, it has some incidence of visual disturbances, which is maybe sometimes can be maybe reversible, means once discontinued the treatment, this visual disturbance will go. There is no significant, and this one of the advantage actually, it has no significant interaction with other cardiac medication, which is very good. Especially all of you know that many of the cardiac medication and many of the common medication used for cardiac patient has incidence of interaction. So this one should be of advantage. trimetazidine, this is a second agent of the relatively new anti-ischemic. Okay, trimetazidine actually also is very very unique in the mechanism, because it is the only anti-ischemic is working on maybe the cardiac metabolism. The cardiac metabolism means make the cardiac tissue utilize less oxygen consumption by switching the energy substrate, the ATP production, to be more dependent on the glucose oxidation. The place and therapy, trimetazidine, I think many of you may know this one, the Bastrel, or very common medication. It has been used as a monotherapy or in combination with anti-ischemic agents, and it has been in the market since very long. But actually, there is no large clinical trial, large outcome trial is really recently supporting trimetazidine, but there is so many trials, small trials, especially in Europe, have been supporting trimetazidine as one of the effective anti-ischemic medication. So it is effective in getting this maybe achieving symptomatic relief, and also as effective as nifedipine and propranolol with lower incidence of the side effect. This is the evidence of the trial. Trimetazidine is not that recommended in patients with advanced CKD, so it has been used with caution in general. There are maybe many reports of higher incidence of Parkinson's symptoms among patients with trimetazidine. Okay, again, if you want to make it clear here, trimetazidine doesn't cause Parkinson's, okay? But some observational reports say, okay, the Parkinson's symptoms seems to be higher among patients on trimetazidine, okay? So this one need more investigation. Of course, it is a good choice as a combination therapy with a classical hemodynamic drugs. We can see here it has no effect in the hemodynamics, So as a combination therapy with other agents that effective hemodynamics, okay, this one will be a good combination, like nitrates, for example, and like the other vasodilator. Okay, brother and sister.
Okay, doctor.
Okay. You should assign maybe one to say okay, and then we can proceed. Ronaldine or ranolazine. Ranolazine actually one of the agents that can use or work mainly on the late sodium current as an inhibitor of the late sodium current, and in general, this will lead to reducing the myocardial oxygen demand. The place and therapy, additional therapy. It has to be add on to others, and for symptomatic control, and maybe the range of between 500 to 2 grams daily. One of the point, it has beneficial effect in glycemic control. It has been shown to be associated with decrease in hemoglobin A1C in patients with or without diabetes, and this may be of relative advantage in patients with diabetes. If you have many options and the diabetic patient not well controlled, so maybe of one of the point you consider. It was not found to be beneficial in patients have incomplete revascularization. In patient undergoing revascularization doesn't get much benefit of this agent. It should be used with caution, of course, in patients with prolonged QTC interval, liver cirrhosis, and stage 4 CKD. The common side effect in general dizziness, constipation, and nausea. Actually, it is very important, brother and sister, to understand the main clinical notes for each and every medication. And based on this one, you can later, inshallah, formulate or recommend and optimize the choices of the medication in a given case. Next, so we have now how many anti-ischemic medication we take up to now? You may count and say after this one, inshallah. Nicorandil actually, unlike the previous one, it is this one is working on the potassium channel. So this activates the potassium channel, and at the same time, it has a nitrate-like properties. So in terms of efficacy, it seems to be the same efficacy like the beta blockers, the CCB, and nitrates. Seems, but in terms of palliative therapy, means in the guidelines recommend as monotherapy or additional this add-on therapy. And like the nitrate, the tolerance can be there. And reported some ulceration has been reported, and if found, if patient at risk, it has to be discontinued. And of course, ulceration and aspirin, we have to be careful. So how many anti-ischemic medication we take so far? Brother and sister?
Anti-ischemic, right?
Yeah, anti-ischemic, the one we discussed today. Okay, the traditional 7. Okay.
7. Yes.
7. Okay, the traditional are 3. Can you name the others? The ivapradine, okay, the ivapradine and trimetazidine, ranolazine, nicorandil, right?
Yes, doctor.
Okay, this all regarding the anti-ischemic. So to put all together here, the optimal medical therapy, this from the latest CBG. So pharmacological management with stable coronary artery disease should be around these agents. So we have the prevention of the cardiovascular events, you can see here, and the relieving symptoms. Prevention of cardiovascular events, you have the recommendation for using aspirin, statin, and plus or minus non-statin. This another point we'll discuss inshallah on hyperlipidemia. Patient with depressed left ventricular ejection fraction, we talk about the ACE inhibitor and other agents to be added, and I think also has been mentioned heart failure. Relieving symptoms, the one we have highlighted mainly today, the beta blocker, the CCP as a first-line agents, ivapradine, trimetazidine, longer-acting nitrate, ronalzine, and nicorandil is not here, are recommended as add-on therapy in patients who remain symptomatic, in given case. And the optimal medical therapy means the medication or the guidelines directed medical therapy, the medication should be instituted prior to revascularization procedure. Okay, clear? So now, alhamdulillah, we finished the pharmacotherapy. So we just end with 2 minor points. The points regarding the revascularization, just for our understanding, actually, revascularization, this procedure will be done, and usually the pharmacist has no major contribution in this procedure. But as a pharmacist caring about this patient, we have to understand the revascularization when and how and to whom. So decision for revascularization in patient with a stable coronary artery disease will consider the symptoms and how interfering with the quality of life, will consider the extent of the ischemia, will consider the severity of the coronary stenosis. And this severity of coronary stenosis usually assessed by measuring the fractional flow reserve. Fractional flow reserve is a value give us indication on the coronary stenosis status, how severe the coronary stenosis is. And usually in lower value, maybe 0.75 and low, the revascularization most likely will be more beneficial than the optimal medical therapy. Within 0.75 to 0.8, it has maybe to be subjected to the clinical judgment. More than 0.8 is okay, no benefit of revascularization, and just can take the medication. Revascularization can provide survival advantage, of course, and revascularization, brothers and sisters, can be done mainly as coronary artery bypass graft when this blocked artery is bypassed with a vessel taken from another part from the patient body. Okay, this healthy one will replace this one and will take bypass for the blocked artery. Okay, this is a major procedure, actually, major procedure. Unlike the BCI, the BCI actually is a stent or balloon. There's a noise. Maybe we can check. We can check and let's we'll mute our mic. So here the coronary artery bypass graft. Here the ballooning of the PCI, percutaneous coronary intervention. This the dilatation with the balloon catheter, so we can resolve any blockage, if any. Okay. Which one? It depends. But usually the cabbage is much more preferred compared to the BCI, and the 5-year mortality compared to the BCI and medical therapy have been shown in those patients are indicated for the cabbage or the coronary artery bypass graft. Okay. Okay. Last point before we do the summary, inshallah. Is the special population. Special population, usually the stable coronary artery disease can happen in patients with the common comorbid condition. One of the common comorbid condition, of course, the diabetes. It is well established that diabetes, coronary artery disease equivalent, and the mortality of the coronary artery disease in diabetic men or women, even times compared to the non-diabetic, and the poor glycemic control, the incidence and the severity of the cardiovascular disease. In general, diabetics have or are expected to have extensive cardiovascular disease due to so many other reasons. Usually, multivessel will be implicated, and stenosis will be there. Maybe the recurrence risk is very high, even post the procedure. Conventional therapy indication for coronary revascularization similar, means diabetic patients are, according to the clinical guidelines, should be managed for the cardiac status as the normal or as a non-diabetic. Okay, but a diabetic patient should have more extensive consideration for the management related to the diabetes, means which agent of the diabetic agent can be of the maximum benefit, in patients with cardiovascular disease. In this actually point, we have very hot topic about the cardiovascular outcome of the anti-diabetic medication. Means those medications used to treat diabetes, do they benefit or harm the heart? Do they have maybe beneficial effect or harmful effect or no effect? And this one, I think our group we have published one of the recent review regarding this one. If you are interested, I can share with you, inshallah, later. So in this point, in general, just to summarize, we have two classes of the anti-diabetic pharmacotherapy that have been shown to have a beneficial impact on the cardiovascular outcome. One of them, the sodium glucose transporter 2 inhibitor, and the GLP-1 glucagon-like peptide 1 agonist. And also, I think we should, inshallah, I think sure Dr. Eid have highlighted this for you, The SGLT2 inhibitor also have maybe a particular protective effect even in heart failure diabetic patient. What about the harmful and not recommended? Actually, the thiazolidinediones, the pioglitazone, the rosiglitazone, all these have been shown to increase the incidence of the heart failure. DPP4 inhibitor, this class, one agent only have been shown in one trial to increase the hospitalization for the heart failure, but not actually harmful for the ischemia. And this is only in this class, this a drug, not a class effect. Elderly patient, same benefit from all the intervention, except we have to be more vigilant for maybe the polypharmacy, the drug interaction, the one I highlighted earlier, which agent can be of higher or lower risk of drug interaction with others. And in patient more than 65 years, in terms of the intervention, for example, for them the cabbage will be more better outcome. And relatively older patient, maybe more than 75 years, will have significantly high mortality if they go for procedure like the BCI compared to the cabbage. Last one in the special population is the chronic kidney disease. Chronic kidney disease, there is no maybe extensive data on CAD and CKD together, but of course maybe the general control of maybe the lifestyle and the medication and the blood pressure and glycemic control will be generally important. To what extent is not that well established. In general, when patient with advanced CKD, the strict glycemic control was found to be very helpful. Okay, it is not that beneficial. Strict means targeting lower value of hemoglobin A1C than the recommended. What do you mean by strict? Some evidence also show the cardiovascular risk reduction with aspirin in patient with CKD is maybe can be achieved through the aspirin. However, maybe a very cautious look should consider the risk of bleeding in those patients. Statin is recommended in CKD in general, but in hemodialysis, if patient doesn't take any statin before, and then he initiated hemodialysis, in those group of patients, it doesn't demonstrate maybe benefit. Also, we have a combination, the statin and ezetimibe. This one, inshallah, we can discuss later. But this combination in general show benefit in terms of the reducing the risk of the cardiovascular events, although it didn't affect the mortality. Okay, so the events can be decreased by the overall mortality is not that affected. This reduction is non-fatal, it can rational for statin use in CKD patients. So in general, as I mentioned, in general, statin are recommended in CKD, except for those patients doesn't receive a statin before and they already on dialysis. Those patients doesn't get so much benefit. Okay, so alhamdulillah, we come to an end. Now the summary. Brother and sister, I need one help from you. Anyone to help? Brother and sisters? Anyone want to volunteer? Volunteer, her or himself? Assalamu alaikum.
I'm sorry, the internet connection is not good. Can you ask?
And the internet connection is since when?
I miss the.
Oh, okay. No. I just very simple. I just want any volunteer because this figure or this summary is just to whatever what we have explained maybe yesterday and today. So I want anyone just to explain this this figure for us. This actually similar what you have discussed: the management of stable CAD, symptom control, prevention, and. So anyone want to volunteer, him or herself?
There are two types of drug that can help to manage the stable CAD. The first one, we can choose the drugs that control the symptoms only. And the next one, we can use the drug for the prevention of cardiovascular events. And there are the listed drugs that can help. And the one that we learned today for this is symptom control. And yesterday is for the prevention of cardiovascular events.
Excellent. Thank you so much. I will not add to appreciate the effort you have done. I will not add more regarding this one. I think the next one is almost the same, but with relatively more details. Anyone want to maybe volunteer for this one? The idea is the same. Oh, yeah. Here the stable ischemic heart disease. Here same, but with a higher or larger scope for the risk factor modification all together, including the lifestyle modification, the annual vaccination, the management of comorbidities, and the other medication. The rest, or the other side, will be what we have discussed today, as our sister mentioned, regarding the anti-anginal or the symptomatic treatment or the anti-ischemic. Okay, considering the use of nitrates, the beta blocker, the non-dihydropiridine CCP, and so many other agents as required. And toward the end, it will be subjected to evaluate the need of the revascularization, either the PCI or the cabbage as needed. Okay. Okay, sister. You want to add something, sister? Okay. Thank you so much. So just to finish our topic, we have all the time any plan or any intervention or any recommendation should keep in mind the evaluation, the assessment. So assessment of the therapeutic outcome in the stable ischemic heart disease, of course, should be focused on, again, two main domains. One domain related, of course, to the point with the prevention of cardiovascular events, means the points related to the mortality. So in this point, we are focusing on the endpoints related to the events and the mortality and this one can be evaluated maybe from time to time, 2 months, 6 months, and where appropriate. It depends individual cases. And we have another outcomes related to the symptom control and the quality of life, of the patient. And in this category, we are more toward the number and frequency of the angina episodes, how frequent the patients need to have or to receive his or her sublingual GTN, how good the patient can engage him or herself in the exercise, and what is the exercise tolerance and the exercise capacity, and how about the duration of the exercise that the patient used to do, how the quality of this one, how the duration is improving or is maintained or is deteriorating. All these may be indicators or proxies can just give us indication of the outcome related to the improvement in the symptoms. So we have outcome related to improvement in the mortality and outcome related to improvement in the symptoms. With that, I think I have finished. the content on my part. And I think inshallah we will be able later in the tutorial to have some cases, so we discuss with some examples, but I prefer to the cases to be after the ACS because it is quite related topics. You will see inshallah next week. It's quite related topics, ACS and IHD, stable IHD. With that, I finished. I will give a few minutes if anyone has any queries, any comments, so you can write in the chat or unmute the mic. Any comments, any points, any feedback, anything? Okay, in case no more questions, and in case you remember any comments or any questions after we finish the meeting, don't hesitate to write in the chat so I can maybe see reply and all of us can benefit, no problem. Or send an email, whatever the channel. You have so many channels to communicate the points that you have regarding the content. With that, I can inshallah end the session by tasbih, kaffara, and surah al-asr. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. بسم الله الرحمن الرحيم. إن الإنسان في خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين. Thank you so much. Assalamu alaikum.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Okay.
Thank you, Doctor.
Thank you.